everyone. Welcome to this virtual session of the I Reclaim 2025 HS Summit. Thank you for tuning in. We're going to be discussing some of the comorbidities associated with HS. My name's Robyn Koo. I'm a current third-year medical student at Duke, and then I'm joined by Melanie Jun, who's a second-year medical student at the University of New Mexico, and Dr. Sydney Martin, who just graduated from medical school at UIC at Chicago, and we are all ambassadors with the International Association of HS Network. And we're collaborating with the Association of HS and Inflammatory Diseases, as well as the HS Foundation, to bring you this presentation. So just some background. Studies have shown that HS is associated with more comorbidities than other inflammatory skin conditions, including eczema, psoriasis. There's also an increased mortality risk that's been reported in HS patients that have over 5 comorbidities. And these comorbidities can span multiple organ systems, including the cardiovascular system, endocrine, gastrointestinal, musculoskeletal, psychosocial, as well as reproductive health. And this causes a large disease burden that can affect someone's physical, psychological, and social health. And that's why we would like to have more early recognition screening as well as multidisciplinary care for HS management for these patients. Starting off with the cardiovascular system, if you have HS, you are at an increased risk of developing hypertension, also known as high blood pressure. And this is defined as a blood pressure that's greater than or equal to 130/80. And then you also have increased risks of hyperlipidemia, which is also known as high cholesterol. And this is defined as a total cholesterol that's greater than 200. Finally, you can have an increased risk of coronary artery disease, which is just the buildup of fats and other substances in the blood vessels that supply blood to your heart. And this can result in complications, including chest pain, a heart attack, and heart failure. And some of the mechanisms that result in this increased risk are chronic inflammation, and you can see this in elevated inflammatory markers such as ESR, CRP, and TNF alpha. As I said before, early screening for these risk factors and proper management of them is crucial. For high blood pressure, you can have office and home blood pressure monitoring. So, purchasing a blood pressure cuff just to make sure your blood pressures are on a normal range is really helpful. For the high cholesterol, you can get a blood test called a lipid panel, and this will measure how much LDL or bad cholesterol, HDL or good cholesterol, and triglycerides are in your system. There are a lot of risk factors for coronary artery disease that you can assess, including family history of coronary artery disease, smoking, hypertension, hyperlipidemia, as we talked about, and as well as diabetes, obesity, and a lack of exercise in your daily routine. Some ways that coronary artery disease is diagnosed includes other blood tests, an ECG, which measures the electrical activity of your heart, an echocardiogram, which is like an ultrasound that images your heart, stress tests, and the gold standard is currently the CT coronary angiogram. Just moving on to the endocrine system now, there are two main comorbidities that are associated with HS. The first one is metabolic syndrome, and that includes meeting at least 3 of the following 5 criteria. The first one is abdominal obesity, and this means having a waist circumference that's over 35 inches in women or over 40 inches in men. The second one is hypertension, which we previously talked about. The third is insulin resistance, and this can be having a fasting blood glucose that's greater than or equal to 100. The fourth is high triglyceride levels, which is to 150 milligrams per deciliter. And then finally, there's having a low HDL, which is the good cholesterol, and that is less than or equal to 50 in women or less than or equal to 40 in men. The second main comorbidity is polycystic ovary syndrome, or PCOS, and that requires meeting at least 2 of the following criteria. The first being having irregular periods. So this means having cycles that last less than 21 days or greater than 35 days. And then the second one is criteria would be hyperandrogenism, and this can manifest as excess facial or body hair, severe acne, and hair loss. And finally, having polycystic ovaries, which can be evaluated using a pelvic exam, blood tests, and as well as an ultrasound that looks at your ovaries. And some considerations for evaluating for these comorbidities, includes having a multidisciplinary approach. So you can see your primary care provider who can refer you to an endocrinologist, a gynecologist, and a nutritionist to help you manage these conditions.
Hello, everyone. My name is Melanie. Thank you, Robyn, and I will continue the discussion on comorbidities of HS. For the gastrointestinal system, inflammatory bowel disease and non-alcoholic fatty liver disease are two comorbidities. For IBD, Crohn's disease has a more high prevalence than ulcerative colitis. IBD and HS both share common gene mutations, such as the NOD2 mutation. For non-alcoholic fatty liver disease, if risk factors are present, a liver function test is advised. It is key to remember for primary care providers and dermatologists that they should screen for symptoms of IBD and non-alcoholic fatty liver disease for symptoms such as abdominal pain, diarrhea, and more. For the musculoskeletal system, spondyloarthritis, including ankylosing spondylitis, which can present as inflammatory back pain, inflammation of the tendon or ligament, such as the Achilles tendon, and dactylitis, also known as sausage digits, is a common comorbidity. Arthropathy is also another. The mechanism of both of these is immune dysregulation, commonly the TNF alpha levels. A clinical tip is to screen for joint pain or joint stiffness. It is important to consider a referral with rheumatology if screening for either of these is positive. HS has many comorbidities with psychosocial and mental health. Depression, which can be assessed with a PHQ-2 questionnaire, as well as anxiety, which can be assessed with a GAD-7 questionnaire, and substance use disorders of opioids, alcohol, or others, as well as sexual dysfunction, which can be assessed with a sexual health assessment, are all important comorbidities that one should consider. Important contributing factors include chronic pain and disfigurement, social isolation and stigma, as well as systemic inflammation, which can affect one's mood regulation. For management, it is important to have early mental health screenings as well as integrated care models for each patient, as well as considerations for FMLA and Social Security disability insurance. Finally, for the renal and neurological system, important possible associations, even though previous literature doesn't include much strong evidence, include chronic kidney disease, which is related to hypertension, and diabetes mellitus, which Robyn was generous to bring up in her previous slides, as well as recurrent UTIs or urinary tract infections, and these can be associated with fistulas and perineal HS. For management, it is always important to consider an evaluation with a nephrologist for complex and/or treatment-resistant cases.
Thank you, Melanie and Robyn. I am going to wrap us up and talk about the skin, which is the organ system that has us discussing this topic in the first place. So the first thing I want to talk about is this quotation on the screen, follicular occlusion tetrad. This is a fancy way of saying that HS is associated with other skin diseases, and some that we have listed on the screen is acne conglobata, pilonidal disease, and here you see a pilonidal cyst, which is a cyst that commonly occurs in the gluteal folds, and then also dissecting cellulitis of the scalp, which is basically inflammation, which is also a driver of HS. It causes pus-filled lumps in the scalp, and it often leads to scarring and hair loss. Pyoderma gangrenosum is very, very important and correlation with PG for short. And we see this on the screen. It's these ulcers that causes pain, and they can occur anywhere on the body. And then also psoriasis as well. And Then we also wanted to talk about overlapping syndromes. So there's a few fancy like terms here, but basically there are syndromes in the literature that link HS to other conditions, and a lot of them are related to inflammation. By no surprise. So the first one is Sappho syndrome. So synovitis is the medical term for joint inflammation, which can be seen with HS, acne, pustulosis. And pustulosis is basically pustules that can occur in different areas. One common pustulosis disease is palmoplantar pustulosis, where you see them on the palms and the feet. Hyperostosis, which is excess bone growth, and then osteitis, which is bone inflammation. So you see inflammation and things occurring in different areas of the body. And then the next overlapping syndrome is PASH and PUPASH. I believe that these are one of the most documented overlapping syndromes in the literature with HS. And this is basically pyoderma gangrenosum, which we see on the side. These are those painful ulcerative lesions, acne, and HS. And they can kind of come in groups together, and that's why we call them overlapping syndromes. PUPASH is just PA added on the beginning of it, and it's adding pyogenic arthritis, which is another term for septic arthritis, which can be infectious with bacterial or any other thing causing arthritis. And then, as we talked about with a lot of other organ systems, there are inflammatory markers that that can be related to these other skin conditions, specifically TNF alpha and IL-1. And then we wanted to add a slide on its own about Down syndrome. We found in the literature that people with Down syndrome have a higher prevalence of HS in general. And studies are also showing that um, patients with Down syndrome are getting diagnosed at a younger age of onset for HS. So the pathogenesis of Down syndrome that's pretty well known is these amyloid deposits that they're precursor proteins and they deposit in the body. And it's thought that these depositions can deposit in the follicles and cause follicular plugging, and then subsequently lead to HS. So, recommendations for this, there's a lot still to study about it, as many other things, but people with Down syndrome should undergo routine screening for HS. So, if you know someone with Down syndrome, whether it's a family member, a friend, it may not hurt to bring it up to a provider to just check common HS sites to see so we can get early detection for HS if it's occurring. And then wrapping up, we are so thankful to have this talk. Some takeaway points from Robyn, Melanie, and myself is that HS is a systemic inflammatory disease, which I believe many people on this call probably know, with comorbidities that span across almost every organ system. We hit many of them, but there's still more, and we're still finding out new comorbidities day by day. Inflammation, hormonal dysregulation, and lifestyle factors play a central role in HS. So we know it's not one specific thing, and it's kind of and it's not one size fits all. So we need to address all these factors. And then the biggest thing here is multidisciplinary care is really essential for patients with HS. So don't feel bad to advocate for yourself. Whether you have like chest pain or risk factors that Robyn stated earlier, and you're like, I may need to go to the cardiologist, whether you're having some joint pain and you may need to say like, hey, maybe I should go to rheumatology, or having some stomach symptoms and may want to go to the gastrointestinal. It's never feel bad or shy to advocate and ask your provider about these conditions, because a lot of times referrals are needed. And as I stated, in the literature, we're constantly getting more information. So it's good to stay up to date. And we're so happy that you guys are tuning in and listening to our call about these comorbidities. And then the last thing is just early identification and proactive management can really reduce morbidity and improve your overall quality of life. And that's why we're giving this presentation to you today. So, if you have any questions, please feel free to email us at info@iahsn.org. Again, we are part of the ambassador group for the International Association of HS Network. We want to thank Jasmine and the Association of HS and Inflammatory Diseases for allowing us to share our knowledge with this amazing community, and then also the HS Foundation for constantly supporting our endeavors. We do have a link as well here for our Instagram social media, which is IAHSN_org. And please feel free to email us if you have any questions about anything we spoke about or are unsure. We will be happy to respond to you offline. Thank you all.